The EMPACT-MI trial compared the SGLT2 inhibitor empagliflozin versus placebo in patients with a recent acute coronary syndrome. The overall trial found safety of an SGLT2 inhibitor in this setting. In terms of efficacy, while the primary endpoint wasn't met, the total of heart failure adverse events was actually significantly reduced with the SGLT2 inhibitor empagliflozin versus placebo. So these data add to the wealth of data at this point showing the benefit of SGLT2 inhibitors in reducing heart failure outcomes in at-risk populations, whether they're patients with diabetes, patients with heart failure, patients with chronic kidney disease, and in this case, patients with acute coronary syndromes. What was not entirely examined in that initial report in the New England Journal of Medicine was the effect on kidney outcomes. And that's what we've examined now, and this work was recently published in Nature Cardiovascular Medicine. What we did in this analysis was examine the effects on kidney function, on adverse events related to kidney function, to see if, first of all, it was safe to start an SGLT2 inhibitor in this setting of a recent acute coronary syndrome, and whether there was any benefit beyond what we initially showed with respect to heart failure adverse events. It's important to realize that in patients started on an SGLT2 inhibitor, there might be a decline in the eGFR, the estimated glomerular filtration rate, in the first couple of weeks after initiation. But in general, there is recovery by about week 4. This is true in general with SGLT2 inhibitors. It's particularly notable in acute coronary syndrome patients where we might be worried that a patient that had an ACS is at risk for kidney dysfunction. A patient with acute coronary syndromes who gets a cardiac catheterization, an intravenous, or in the case of a catheterization, intracoronary diload that might alter kidney function. In this milieu, would it be safe to introduce an SGLT2 inhibitor? There were legitimate concerns about this. But what we found was, in fact, it is safe to start an SGLT2 inhibitor in this setting. Now, having said that, one does need to be careful and need to be mindful of the overall kidney function, changes in kidney function, concomitant medications that might affect kidney function. But as a general statement, I think it's fair to say that in the EMPACT-MI trial, in patients with ACS, it was indeed safe to start an SGLT2 inhibitor. Now, what causes that early drop is really multifactorial. The SGLT2 inhibitors have multiple effects on the kidney, for that matter, on the heart as well. One of the effects they have is as a bit of a diuretic. So one tip in starting an SGLT2 inhibitor is if the patient is already on a diuretic, especially if the kidney function seems somewhat tenuous, it might be a good idea to back off on the dose of the diuretic. Again, that depends on not just their kidney function, but their overall volume status, whether they do or don't have symptomatic heart failure. But the bottom line is that as physicians, we shouldn't necessarily be scared by an early decline in the eGFR on initiating an SGLT2 inhibitor, and for that reason alone, stop it. In fact, this is something that's also noted with things like ACE inhibitors or angiotensin receptor blockers, though with longer-term follow-up, SGLT2 inhibitors and those other drugs I mentioned do have kidney protective effects. So yes, there can be a dip in measurements of kidney function initially, but mustn't overreact to that. So what we saw in EMPACT-MI was that over time in those patients where the kidney function was measured, that it was stable in those patients on empagliflozin, but declined, that is worsened, in the patients on placebo. So essentially when you compare the two, there was a significant benefit in favor of empagliflozin versus placebo. So these data add together data for this class of medicines, SGLT2 inhibitors, showing that they have kidney protective effects. Now, this benefit is magnified in patients with heart failure or patients with diminished kidney function to start. In fact, there's a lot of overlap between those two populations. And the reason that SGLT2 inhibitors such as empagliflozin have a benefit on kidney function is really due to multiple different effects that they have. And it's really been well demonstrated in trials of patients with kidney disease, dedicated trials in patients with CKD, that this protective effect is real and reproducible and appears to be a class effect across SGLT2 and, for that matter, SGLT1 combined SGLT2 inhibitors as well. So a class effect, but we demonstrated very nicely, I think, in an ACS population, which hadn't been done before, that SGLT2 inhibitors, in fact, are overall safe from a kidney perspective, and also efficacious from a kidney perspective. It was reassuring to see that the benefits of empagliflozin in the EMPACT-MI trial were so consistent across various subgroups. As we examined the effect on kidney function, it seemed to be a consistent benefit even in patients with diminished kidney function to start, that is, on the lower range of the eGFR spectrum. So to me, that's really very encouraging data showing that SGLT2 inhibitors, empagliflozin specifically in this case, but I do think it can be generalized to the class of drugs, that SGLT2 inhibitors help preserve kidney function, even in those that start off with pretty bad kidney function. And this is consistent with the labeling in most parts of the world for the SGLT2 inhibitors, where even down to an eGFR of 20, it seems like a good strategy to start these medicines, and in fact that they help preserve kidney function. Of course, one does need to be careful when using SGLT2 inhibitors in this range of GFR. These sorts of patients really should also be under the care of a nephrologist, because not due to the SGLT2 inhibitor, but if their eGFR is that low to begin with, well, dialysis is something that's potentially in their future. And of course, steps to try to prevent that, such as SGLT2 inhibition, are generally warranted, but must be done with care and with caution. But the benefit across the various subgroups of diminished kidney function is really an important finding, I think. So in addition to the kidney benefits, there was also a reduction in heart failure type events with empagliflozin versus placebo in EMPACT-MI. And it is, in fact, the case that heart failure and kidney dysfunction are interconnected in many ways. That is, heart failure can contribute to kidney dysfunction, and likewise, pre-existing kidney dysfunction makes the treatment of heart failure more complex, because many of the medicines that we use to treat heart failure end up affecting kidney function deleteriously. So it's a bit of a vicious circle, each making the other worse and each coexisting oftentimes. So it is really tricky when both these conditions are present. But fortunately, SGLT2 inhibitors, as we saw with empagliflozin EMPACT-MI, can be particularly useful not only to prevent heart failure events in patients with varying degrees of kidney dysfunction, but likewise in patients with varying degrees of kidney dysfunction, heart failure events are also reduced. So it goes in both directions. That is, reductions in heart failure events across kidney dysfunction and reductions in kidney events across levels of kidney dysfunction. And the coexistence of both of these two disease states, which is common, is well addressed by SGLT2 inhibitors. Well, with respect to low blood pressure, there one does need to be a bit cautious. SGLT2 inhibitors do lower blood pressure by a little bit, but that is not so much an issue when the blood pressure is normal or low to begin with. But if someone had symptomatic low blood pressure, then you really do need to think twice about starting SGLT2 inhibitor in that context. You have to figure out why their blood pressure is low and correct it. Oftentimes in the heart failure patient, that's because of excessive volume depletion, perhaps from diuretic use. And if one backs off on the diuretic and the blood pressure normalizes, then initiation of an SGLT2 inhibitor is typically safe. As far as patients with pre-existing kidney dysfunction, there as well, SGLT2 inhibitors can be safely initiated. We've seen that in prior trials of patients with chronic kidney disease. As well, in EMPACT-MI, we see that it's safe to initiate an SGLT2 inhibitor, even in an ACS patient with poor kidney function. So a patient, that is somewhat high risk, but nonetheless, it did seem safe to start the SGLT2 inhibitors, safe overall, but safe also with respect to kidney function. But one has to do this with careful monitoring of the kidney function, the patient's volume status, and of the patient overall. Well, preserved ejection fraction has already been studied. We first showed in the SOLOIST trial, as published in New England Journal of Medicine with sotagliflozin, a mixed SGLT1/2 inhibitor, a significant benefit in the subgroup of patients with heart failure with preserved ejection fraction, as we did in the overall trial in patients with acute decompensated heart failure who were then stabilized. And then subsequently, trials of both empagliflozin and dapagliflozin showed benefits specifically in patients with heart failure with preserved ejection fraction, either with or without diabetes. So that, I'd say, is already pretty well known. One could still ask questions like, is there a difference between SGLT1/2 inhibitors versus SGLT2 inhibitors? Those type of trials would be really interesting to see if there are any incremental benefits of SGLT1/2 blockade over SGLT2 blockade alone. But in terms of heart failure with preserved ejection fraction, the jury's in. SGLT2 inhibitors are indicated unless there's some contraindication. Really, the evidence for SGLT2 inhibitors in both heart failure with reduced and preserved ejection fraction at this point is incontrovertible. As far as EMPACT-MI goes, these were patients with acute coronary syndromes, and there, I wouldn't say acute coronary syndromes per se are an indication to use an SGLT2 inhibitor. We need more study to really prove that. What EMPACT-MI tells me, at least in terms of conclusions, is that if we have an ACS patient who otherwise should be on an SGLT2 inhibitor, such as a patient with diabetes or with heart failure, with either reduced or preserved ejection fraction, or with chronic kidney disease, we should use an SGLT2 inhibitor for those reasons and not be scared to use it just because the patient had come in with an ACS. Of course, you want the patient to first be stabilized. You wouldn't want to do this in someone, say, that's in shock or critically ill. But once they've been stabilized towards the end of that ACS hospitalization, then I think it is safe and, in fact, a good idea to start an SGLT2 inhibitor if they meet those other indications. But I wouldn't say that EMPACT-MI, for example, in a patient without heart failure or without chronic kidney disease, without diabetes, provides any compelling argument to start an SGLT2 inhibitor. To do that, I think we would need another larger trial. And there, that would be a good sort of trial to do with an SGLT1/2 inhibitor, where that class of agents also has an effect on ischemic endpoints, which we didn't see in EMPACT-MI, where empagliflozin didn't reduce MI or stroke. For that matter, a trial of dapagliflozin in ACS patients also didn't show a reduction in MI or stroke, whereas sotagliflozin in the SCORED trial of patients with diabetes and chronic kidney disease did show a significant reduction in MI and stroke, as recently published in Lancet Diabetes and Endocrinology. So definitely a room for more research on the topic. But in terms of your question about heart failure with preserved ejection fraction, there I think the bigger challenge is getting the many patients with that condition who aren't on an SGLT2 inhibitor on one. Absolutely. So first of all, the data for SGLT2 inhibitors broadly as a class at this point is extremely large, extremely consistent. The drugs remain underutilized. Some of that has to do with cost, but the drugs will be going generic in the next couple of years worldwide. So hopefully cost won't be so much of an issue. But even now, there are certainly patients where they should be used despite the potential issues with cost because of the overwhelming amount of evidence from randomized clinical trials, the guideline endorsement of SGLT2 inhibitors. So in particular, in patients with heart failure with either reduced or preserved ejection fraction or with chronic kidney disease, and in these patients with or without diabetes, they really should be on an SGLT2 inhibitor unless there's a contraindication. And I'd go one step beyond to say even for patients without heart failure or without chronic kidney disease, if they have diabetes and there's no contraindication, really SGLT2 inhibitors is something that should be strongly considered, along with GLP-1 agonists or dual incretins. I mean, these are agents that are much better than the older diabetes drugs. And if one puts aside the cost issues, these are drugs and drug classes that have marked benefits on cardiovascular endpoints and also kidney endpoints in patients with diabetes. So those are the type of patients where I think SGLT2 inhibitors really should be used unless there's a contraindication.